Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. Thanks once again for your company. In this programme we take a look at respiratory pain. We'll speak with chest physician Dr Peter Kendall and respiratory scientist Bill Smith from Fremantle Hospital. But before we begin, I'd like to tell you about an upcoming conference. The Rural Clinical School of Western Australia and Rural Health West invite you to the Building the Future of Rural Health conference. And this year's conference, Evidence and Emotion, will be held at the Albany Entertainment Centre from the 21st to the 23rd of September, and it explores aspects of the science and art of rural medical practice. The conference will provide an opportunity for GPs, researchers, health professionals and medical students to share ideas, form collaborations and network with speakers and other delegates. The keynote speakers will include Dr Eric Cassell and Ms Patricia Owens, both from the US, Dr Chris Luscombe from Canada and our own Dr Richard Murray, who's joining us from Townsville. The conference offers clinical, educational and upskilling workshops covering obstetrics, orthopaedic emergencies, Implanon NXT insertion and removal and Marina Haptic 3D simulator training. All workshops require pre-registration and places are limited, so make sure you get in early. A full programme overview and registration form can be found on the Rural Health West website at ruralhealthwest.com.au, and we hope to see you there. Well, let's now join Olga Ward and our guests, Dr Peter Kendall and Bill Smith.
Well, this time of the year, coughing seems to be the most common thing that GPs see in the surgery. When do you start to get worried?
It's the bane of my existence, the coughs. I get worried when we start getting referrals.
Yeah.
But obviously cough can be due to a whole pile of things which GPs know all about and end up solving a vast majority of them, and it's not usually a problem. The cough which is of concern would be that which is persistent, which doesn't respond to simple things, but then there's a post-infective cough that goes for 2 or 3 months quite typically, and most GPs have seen that probably every winter. Yeah. It's difficult to know what to do. If there's a history of that recurrence over time, then maybe that needs to be reviewed, but the question is, what do you do about it? Oftentimes the cough starts with a simple virus. You've got to remember that a virus is just a 2 to 3 day thing, usually up here, sometimes going to the chest if they've got a weakness in that regard. There may be cough and phlegm, and there may be antibiotic use with a bacterial superinfection. But if there's cough persisting, which is a dry cough, then it's no longer the virus nor the infection. So it's probably some form of local irritation using the voice box, sometimes with a postnasal drip, and sometimes made worse by reflux, if it's present, if reflux is otherwise present. And
so it's actually a laryngeal thing.
Yeah, oftentimes it's what I put into the rag bag of vocal cord dysfunction, which is now well recognised around the world as being a significant problem, even though it's not a disease. It's a functional problem of the voice box.
Yeah. And patients are worried about doing tests when they've got a cough.
Yes, I was wondering about that, because quite often, of course, your asthmatics will start coughing and continue to cough, and you want to know where their function's at. How do you deal with that, Bill?
Well, we encourage them to actually blow through the cough, because the cough will only interfere with the results if it occurs within the first second, where you're measuring the FEV1, whereas cough after that point, in fact, doesn't matter, because what you're measuring is volume, so it really doesn't matter whether they cough it out or blow it out, as long as they get it out.
And that's the other point, is that just on symptoms alone, I mean, we think we're fairly accurate in diagnosing chronic lung disease on symptoms alone, but you really need spirometry. I mean, there's no doubt about it. There's another publication just this week coming out of Tasmania where the accuracy of history alone is around about 60%.
So what features of history would be red flags for you for some kind of chronic lung disease?
Well, if you're talking about asthma, then obviously that's a variability in breathlessness and a typically cough and wheezing at the same time. Wheezing is a really important question just to nail down briefly. It's at the very beginning. If you nail it down that it's actually an expiratory noise and not an inspiratory noise, as it commonly is, because the inspiratory noise, of course, is stridor, and it's much less likely to be asthma. It can be asthma, but it's much less likely. It's much more likely to be the voice box that produces the inspiratory noise, and that commonly gets misdiagnosed as asthma. But you can generate all of the symptoms of asthma from your voice box. So you can develop a wheeze and a cough. And of course, if the voice box is close together, then you'll get breathless. So you get breathlessness, wheeze and cough coming from the voice box, and commonly misdiagnosed and commonly coexistent with asthma, which is even worse. And then, of course, made worse by the inhaled steroids, which impact upon the voice box. So it can be a real... I spend a lot of time undoing a diagnosis or teasing out what are the components of a diagnosis so that the patient can manage their problems.
And then when you've got all these post-viral coughs that last for weeks and weeks or months and months, and then the patient gets another virus, and of course that sets them off again.
Yes.
How do you actually manage them?
Yeah, well, it's really difficult. I think trying to nail down the underlying causes. So if there is a postnasal drip, make sure you treat that aggressively with intranasal steroids usually, or possibly antihistamines, although I tend to shy away from them a bit. Make sure the reflux is under control. The gastro guys tell us that 40 milligrams twice daily of the standard PPI is what's needed.
So a really big dose.
As an adequate trial for up to 6 weeks. So most of us don't do that.
No.
Most of us maybe 40 milligrams a day for 3 or 4 weeks. But there are patients in whom a more prolonged trial, and occasionally that should be backed up with a gastro review and actually manometry to see that they've actually got acid reflux happening. I don't tend to go to that extent terribly often. I think a trial of treatment is probably enough most of the time. So that would be the other contributor. And then, of course, any drugs that make people cough or any drugs that dry the mouth is the other thing. So the older-fashioned antipsychotic drugs or even the amitriptyline used at night, not uncommonly in people with lung disease, tends to dry the mouth. And there are lots of other drugs that dry the mouth. And then, of course, there's the ACE inhibitors that actually do make people cough.
So when you say they dry their mouth, you just mean that they'll then kind of be waking up very dry and produce a lot of mucus first thing in the morning, or what?
Yeah. Well, they actually produce a dry mouth. They actually do dry up the flow of saliva, some of these drugs. But then that's a separate issue.
So how does it make them cough?
Because their voice box is chronically irritated.
Oh, right.
So the cough comes from the voice box. Then there's that other group of patients who typically sleep on their back, who snore, who therefore mouth breathing all night, so their voice box is now chronically irritated and dried, and it's primed to get a prolonged cough with a virus. So some of the management of that is to get them to sleep on their side, or if they've actually got sleep apnea, to treat that, and if they need a CPAP machine, they need a humidifier in it to keep things moist. So there's all those upper airway dryness, and of course in this climate in Perth in particular, but it's not so much in the northwest, but where the climate is very dry down here, the air is very dry, plus all our houses are air conditioned, usually with the reverse cycle air conditioning. So so therefore it's very dry. Oftentimes I advise people to buy a humidifier to put in their house. Yeah. The opposite of what you might do in Broome, for instance.
Quite a lot of coughing then appears to be at least related to things like postnasal drip.
Yeah, and dryness.
How fast do you expect a result from one of those steroid nose sprays?
Within a couple of weeks, if it's going to work, then there should be a diminution of the postnasal drip as recognised by the patient. Some people don't recognise it, and hopefully the cough should settle down within a couple of weeks as well. If it doesn't, then it's not the complete answer. And oftentimes you need to treat more than one thing.
But it's a couple of weeks, not a couple of days like the patients expect.
No.
What about things like FES and those other buffered saline washouts that are so popular? Yeah,
I think they have a place, but they really just remove phlegm or mucus from the nasal, and I think they do work, and some people think that they're effective. There's also salt water, of course, in most of the steroid sprays as well. A lot of people unfortunately spend a lot of money on these things as well. And of course, salt water can be made quite easily. It's a level teaspoon of salt to a pint of water, 600 mils of water, and boil it up, and then it's fine for a week.
Add a tiny bit of carb soda and it doesn't sting.
Bit of bicarbonate soda, correct, is a good idea. Yep, just a pinch, yeah.
With the post-nasal drip patients, do you have any particular tricks that you teach them to actually get the stuff that they're snorting up their nose into the right spot?
Yeah, I think it's, I do, yeah. I think it should be done, men tend to clear their nose in the shower, women tend not to, but so I usually say after the shower, but it doesn't really matter, as long as the nose is clear at the time. There has to be, 1 or 2 puffs in each nostril, whatever the prescribed dose is, usually 1 puff in each nostril of the stronger stuff. I do it when they're standing upright. I get them to block one nostril and pop the spray up this way. I tell them to sniff it in a bit. If they sniff hard enough that it's then gone down the back of the throat, it can't work down there, and that's a really common mistake, particularly in men. They snort it in so hard, it goes down the throat and it can't work down there. So just enough of a snifter retained in the nostril. And then I tell everybody to hold the nose and blow to make the ears pop like on an aeroplane, and that forces the spray up the eustachian tubes and partially into the sinuses, and I think that makes a big difference. I'm convinced that that makes a big difference, because I've had a lot of people come along, been chronically on a nasal spray, poor technique. As soon as they get the right technique, they get better within a couple of weeks.
It is a thing to do with technique, isn't it?
Yeah,
Do you have any special tricks that you teach patients, Bill?
Not from a nasal point of view, but certainly in terms of giving them the right tricks from aerosol bronchodilators and the use of spacers, then certainly. And it's a common comment by patients that they've got a puffer and nobody's ever told them about a spacer, or they've got a spacer and nobody's ever told them how to use it properly. And I think that's just a testament to the speed with which we live our lives. So it gives me the opportunity to educate them in that area as well as doing the testing.
I almost never teach people puffer technique. I show them how to use the devices, but I never spend time teaching them as such, because I think if I'm going to use a puffer, a meter dose inhaler, I always use a spacer, and I always teach them how to use a spacer. So I never teach them how to use a puffer without a spacer. I teach them how to use the dry powder inhalers, the capsule ones or whatever, but I never teach people meter dose inhaler technique without a spacer.
Do pharmacists teach patients? Like if you've written a prescription and sent them off, would a pharmacist be expectable to teach that?
I've actually witnessed pharmacists who are filling a prescription for a puffer will say, do you need a spacer with that? Which I've always given them a little mental tick for, but I've never observed them actually showing them how to use it. Pharmacists,
as of about 2 years ago, have a legal duty of care to ensure that over-the-counter preparations like salbutamol, beta-agonists available over the counter are actually being bought for the right person for a good reason and with a reasonable outcome of working. So they actually have a duty of care to actually talk to the people buying over-the-counter preparations in relation to who's it for, what's it for, and how you're going to do it. So the ante's been upped a bit in the last couple of years. We've done some interesting secret shopper work with pharmacies through the university. The guy's just been awarded his PhD, which is really good, the pharmacy student, and it shows quite clearly that we do it very poorly around WA. All of Perth's pharmacies were visited.
Could you tell us a little bit about some of these atypical infections that keep popping up on serology or PCR testing?
Yeah, I don't really know whether or not they contribute to chronic cough. I think chronic cough is nearly always non-infectious or non-infective. It might have started with an infection, but I think we tend to underdiagnose things like mycoplasma infections. I think GPs diagnose it all the time because they see it all the time, and we don't see it in hospitals very much. So I think we tend to underdiagnose it in hospitals, and when they land in sick, I say, oh, that's mycoplasma pneumonia, and everyone looks surprised when it comes back with the right serology. But I think we just don't see it that often in hospitals, but in general practice it'll be seen much more frequently in the older population as well. But some of the other antibody responses have been linked to things like asthma, and there's been lots of studies to say that chronic antibody presence in asthma, for instance, is actually part of the cause of the asthma. And so then there were several studies then giving long-term treatment with drugs like Rulide or roxithromycin or equivalent to try to eliminate so-called chronic infection and to see whether or not the asthma improves. And there's some studies which show that there's some improvement and some that it's not so good. So there's some interesting work. So
jury's still out.
Jury's still out.
So how long would you try with the antibiotic as well?
I think we should be using
2 weeks, 4 weeks?
Yes, standard short courses. The only time I use prolonged antibiotics is when you've got somebody with really blocked sinuses, for instance, or that might need course after course after course. Or then there'll be some people, obviously with things like TB you need prolonged courses, but there'll be some people like lung abscesses and need a long course of penicillin or some such thing. They're quite unusual. I mean, they're not the standard run-of-the-mill things. But the chronic sinus infections commonly need prolonged course of antibiotics with antihistamines and decongestants and stuff as well to try to get things out. Otherwise they need surgery to get a better nasal airway.
And could you talk a little bit about those atypical mycobacteria that, again, often pop up on sputum samples. You think you're being very thorough and you ask for AFBs, and up they come, and all of a sudden the nursing staff want to isolate the patient.
Yeah. So now we're into the realm of bronchiectasis, which is really shouldn't be. You shouldn't be discovering all these funny bugs without bronchiectasis being present. If you do, it's because they've had vastly too many antibiotics, and these bugs have grown out. Therefore, but the atypical mycobacteria, they really probably should be correctly called non-tuberculous mycobacteria. So they're quite typical bugs, but they're just not TB. They're not infectious, obviously, not contagious, so they don't need to be isolated at all. And then we're talking about bronchiectasis, so the typical patient will be middle-aged female, but that doesn't mean it can't be a male, and typically with middle lobe or lingular bronchiectasis, but again it can be elsewhere, and that will be visible on the CT scan, typically with some nodularity, which we call bronchiolitis on the CT scan. And that will be a typical presentation of somebody. So we do the sputum tests, and you find avium intracellulare or some other unusual mycobacterium infection. So the question is, what do you do about it?
Yep.
And in general terms, we don't treat it unless they've actually got a tuberculous illness.
Yep.
So in other words, they're sick, they're febrile, they've got sweats at night, they're losing weight, lots of cough and phlegm, they might be bleeding from the lung, and it's the only bug. Then you have to undertake treatment, and it's a real bugger to treat. It takes about 2 years, multiple drugs, lots of antibiotic sensitivities and things.
So somebody who's reasonably well but is coughing up a lot of, you know, sort of yicky-looking sputum, particularly first thing in the morning, you would just tell them it's probably better just to cough it up and spit it out?
Yeah, this is in the context of a non-smoker you're talking about, or, and they do have bronchiectasis on the, I mean, I'd be doing a CT, a high-resolution CT. So that's a high-res CT without contrast. If you're looking for lung cancer, you do plain CT with contrast. If you're looking for interstitial lung disease or bronchiectasis, you do high-res CT without contrast. Quite different studies. So what I find a lot of errors, if you like, being made by people being sent off for a CT to the local radiologist without any personal communication with the radiologist. What are you actually looking for here? Yeah.
So if you put down, you know, suspect bronchiectasis or chronic cough with sputum, the radiologist would then put the correct thing on?
Much more likely to. So the proper communication with your radiologist gets a better result, and the number of times I see a CT which was a waste of time is quite extraordinary. So if you're looking for cancer, fine, do a thick slices and contrast so you can see the glands versus the vessels. That's why we do it. But if you're looking for interstitial disease or bronchiectasis, you want thin slices, and you don't need contrast.
So bronchiectasis seems a little bit weird to me. Tell me how it actually develops.
Don't know. There are some quite rare genetic causes that people are familiar with, which you see from time to time, but they're not that common. Most of them will be people who've had typically whooping cough or measles in childhood, that sort of stuff. This is away from cystic fibrosis, I might add. Obviously, that's a parcel by itself. So non-CF bronchiectasis we're talking about. And then recurrent infections. Pneumonia itself can cause bronchiectasis, so particularly a necrotising pneumonia or severe pneumonia. Some people
just kind of walls off a little bit of pus or what?
Well, I think the bronchi just get damaged in the process of the infection, and so you're now left with damaged and floppy bronchial tubes. They don't. They blow out when you cough, so phlegm rattles around. So hence you need the physiotherapy to get the clearance. They need to be taught the difference between huffing and coughing, which is important. So huff is an open throat, open voice box thing, as opposed to a cough, which is a closed voice box thing. When people cough, the bronchial tubes further back just blow out, and the phlegm just rattles around. If they huff, it's more likely to get laminar flow, and the mucus will come out. We use a thing called a PEP device, which is a small plastic instrument into which they blow as they exhale, which supplies a resistance to the exhalation. And
that then blows out
splints the bronchial tubes open as they use the active cycle of breathing and their huffing. And so that's what our physios spend a lot of time dealing with our patients. So most of the older-fashioned, tipping and clapping and stuff is cupping is probably out the window a bit. It's still done a bit, but the PEP device is just as effective as that and in the upright position. So older people can do it without having to be tossed around like a sack of potatoes. And the other interesting thing, when they did that study with at the Children's Hospital in Melbourne with kids with CF, they actually used a flutter device, which is the same sort of thing with a little ball that flutters in it. They found that not only was their physiotherapy better, but the FEV1 went up. And they thought that's because they weren't getting so much reflux because they weren't having to tip their children. So that was very interesting. So the outcome appears to be better with these newer physiotherapy devices.
Certainly worthwhile. When you do have patients who've got this chronic cough, they often produce a lot of mucus and sputum sort of first thing in the morning and then it tails off. Is there any place for actually suppressing the cough?
No.
No? Do you ever suppress cough?
No.
So
It has to be that dreadful counterproductive, I call it counterproductive cough, inverted commas, but that doesn't do anybody any good, that you just can't get rid of. And very occasionally you just have to use something like Folcodine Linctus or something like that, but it's vastly expensive. It's not on the PBS.
No.
You go through a bottle in about 4 days and it's just hopeless.
You can constipate them up with codeine, of course.
You can, yeah.
Do you ever suspect lung cancer in non-smoking patients who develop that kind of chronic irritated little...
Not that one, because that one's always the voice box one.
Uh-huh.
But yeah, the chronic cough, particularly if it's productive, I mean, I think you should always say, look, we should do a chest x-ray here. And if the chest x-ray is clear and they've never smoked, then the likelihood of a lung cancer is quite remote.
Yeah.
There's a lot of data now which links lung cancer to not to smoking, or to never smoked. And so there's the genetic stuff and which is coming through, and it dictates some of our treatment for lung cancer now too, which is interesting. So there are components of the genesis of lung cancer which are probably not related to smoking, and some people put it as high as 15 or 20% of the genesis of the lung cancer might not be related to smoking. But I still rarely, if ever, see a person with a lung cancer who hasn't been a smoker.
Yeah.
We do see them every now and then, but they're very rare.
Would you regularly chest x-ray your smokers for screening purposes?
Unfortunately, there has never been any evidence which suggests that screening for lung cancer makes any difference to the outcome. So at present we don't do it. We get the publications probably every week somewhere where they've got screening low-dose CT, for instance, in smokers, and claim some benefit, but it's marginal benefit, and the evidence is still strongly in favour of there being no effective screening tool for lung cancer. That's its biggest problem, because it presents, as you know, quite late, and therefore we only get 15% of people on the table, and the outcome is poor.
Well, there are loads of inhalers on the market of every different colour, and they're all claiming to be the new wonder drug. We're moderately familiar with the standard asthma treatments, but recently there's been a lot of publicity about long-acting beta agonists for COPD, and particularly this new inhaler called On Breeze. Indicatorol. Why would you use it?
Yeah, I don't know the answer to that, and I haven't yet.
What do they do?
Good questions, and I don't know all the answers to that, and the company have really been unable to give me satisfactory answers. The problem with, the thing about long-acting beta agonists is that they do improve symptoms and patients' well-being, I think, and the same as long-acting anticholinergic agents, so that the Spiriva, tiotropium medication, similar results.
And then the old ipratropium, which was Atrovent.
It's important for, and still being done, unfortunately, people having ipratropium at the same time as having tiotropium. It's important for those guys out there to realise that ipratropium inactivates tiotropium, and tiotropium is the better drug. So they should not be used together ever. So a lot of people are still having Atrovent in a nebuliser at the same time as they're using Spiriva once a day. That's completely inappropriate. So that means that they're getting nothing.
Yep.
The long-acting beta agonists have been shown to improve a patient's symptom control and therefore their well-being, if you like, in COPD, but they're really only indicated in the severe COPD, so once the FEV1 is half normal or less, that gets them into the severe category. So inhaled steroids by themselves are not indicated above FEV1 of 50% of normal. So they don't do anything, is the reason. So once you get below 50% of predicted FEV1, if there's definitely a clinical response to long-acting beta agonists, then they can be used and there's some benefit.
Why would you use something like the new on breeze inhaler and not the salmeterol or
yeah, the trouble is we've now got combination agents
Yep.
in both Symbicort and in Seretide
Yep.
with combination long-acting beta agonists and inhaled steroid. Now, this category of patients they're all going to need the inhaled steroid.
Yep.
So why are you going to write them a separate prescription at a separate prescription cost for a separate long-acting beta agonist? So I personally have never used indacaterol, but it's not to say I wouldn't. And there's the odd patient that I've seen who was intolerant of other beta agonists, and in whom I recommended when it becomes on the market, which it will in a couple of months, that might be appropriate.
Yep.
But I just sort of think from an economic point of view, you've got to remember patients have got to pay for these things, and a lot of the people on pensions, and it does impact. So I'm not sure that they found a right niche for that drug yet. Not to say it's not a good drug, perfectly good, long-acting, once a day, long-acting beta agonist.
And with all the lung tissue destruction that you see in emphysema, do you see much response to fitness programs and graded exercise and all those other extraneous things that people do?
Yeah, I think GPs know these things fairly well. The things that we're now talking about COPD, or particularly emphysema in particular, and the other disease being chronic bronchitis in that cluster. But in emphysema, the only things that alter the outcome are to quit smoking, and GPs are good at that, and it is a process, not an event, and it's often very, very difficult, and I think I would urge people to assess the patient's nicotine addiction level. There's a thing called a Fagerstrom score, Fagerstrom, Fagerstrom, starts with fag, I like the word. And if you Google Fagerstrom, you'll find the Fagerstrom index, and you can get quite an accurate index of their nicotine addiction, remembering that nicotine is highly addictive. It's 10 times as addictive as alcohol and twice as addictive as heroin. So it's a very addictive substance. Fortunately, it's just not very harmful of itself. But if they're highly addicted, then they need a lot of support and work to get through withdrawal of tobacco. So no doubt that quitting is the one thing that makes the big difference. The lung function declines at a certain rate, and then it goes off at the rate of non-smokers at the point of quitting.
Yep.
So they buy a lot of time in terms of emphysema whenever they quit. Even if they quit very late, they buy a lot of time.
Yep.
The other thing which a lot of people don't know about that while we're on that subject is that if people quit smoking before the age of 30, they completely avoid the 4-fold increase in mortality from all causes due to smoking. Now, that's a huge epidemiological fact, and we don't tend to target 20-year-olds, and we should.
And there's a Fletcher curve, which I found very useful in showing patients that. Useful because it's positive, gives them a positive message that if they quit smoking, there's a real tangible benefit that they can see on the curve.
Yeah, I draw that curve all the time. So back of the lung function results, I draw that life graph, 20, 40, 60, 80 years of age, and the decline in non-smokers and the decline in smokers, and I plot out where they are on that graph, and estimate their approximate age of death, and on oxygen in a wheelchair sort of discussion, for the 5 or 10 years prior to that, and then draw their line as it is if they quit. I think that's very important. I think part of the process of quitting, it's a very complex process, as you know. Part of it is to link a disease to the habit. If you link the disease to the habit in a tangible sort of way, then people respond to it much more.
Fortunately, your patients mostly do have some kind of chronic disease, and a lot of our patients just have a chronic habit.
Yes, but by the age of 30, they've not uncommonly got a slightly reduced FEV1 or a slightly reduced gas transfer. And if you plot that out, you can see a line going down. So
it might actually be worth sneaking in some spirometry on our 30-year-old smokers just to show them that they're going to shuffle on.
No question about that. No question about that. It's a very powerful tool.
Yep.
So getting on to the other thing which alters the outcome, there are 3 other things apart from the pulmonary rehab program. So there's 2 other things. One is the inhaled steroids, only if FEV1 is less than half normal and the evidence is not that strong. And the last one is home oxygen, if they actually meet the criteria for home oxygen. So getting back to the pulmonary rehab program, what that does is twofold. Firstly, they exercise, because these people tend to decondition because they get breathless when they walk, therefore they don't walk. If they are pushed along with the physio with a whip and they get a bit fitter, the cardiovascular fitness is what happens. What that does is tells their brain to tolerate breathlessness better. So it actually improves their quality of life and their symptoms. Doesn't change the lung function, because it can't. But it tells their brain to tolerate dyspnea better, and therefore they feel better. And that's a very interesting outcome. The other component of the pulmonary rehab program is really upper body strength exercises. So we're talking about push-ups or weights, the sort of exercises that the physios do. Push-ups against the wall for the really frail elderly ones, the push-ups against a bench for a slightly stronger person, tossing a ball against the wall and catching it to get you a bit of hand-eye coordination and balance and vitamin D at the same time. So that's quite a useful exercise.
Yep.
And anything that improves the muscle strength across the shoulder girdles. And the reason is with emphysema, you have increasing lung volume, particularly with residual volume goes up very high, therefore the diaphragms are pushed down flat. The diaphragm is normally curved, and when it contracts, the lungs get bigger. Yep. The diaphragms are flattened with emphysema, and it contracts, the lungs get smaller. So progressive emphysema, progressive hyperinflation takes the diaphragms out of the equation. Therefore we breathe with these weak intercostal and abstract muscles, this weak bucket handle manoeuvre breathing, which you all learnt about when we were at university, and that's what it is. And now preferentially...
That's why they're so exhausted just from breathing.
Correct, and if they get the flu, then these muscles fatigue very quickly, and they land in hospital in ventilatory failure, needing a ventilator. So if we can strengthen them up. So what it's been proven that pulmonary rehab shoulder girdle strength muscles improvement keeps people out of hospital.
And there are a couple of other drugs that, apart from the puffers, that GPs use occasionally. Could you talk about Montelukast?
Yeah, brand name Singulair, 10 milligram tablets, very few side effects, relatively safe medication. It's on the PBS for children, as you know.
Why does it only go up to 16?
Yeah, because there's no evidence that it works, unfortunately. It seems, for some odd reason, that beyond the teenage years, the likelihood of producing any effective outcome is reduced. So, arguably, 10 to 15% of adults will have some response to Montelukast or that class of drugs, typically it'll be the patient who's got aspirin-sensitive asthma or exercise-induced asthma, commonly similar, cold air-induced asthma, or particularly the ones with concomitant bad chronic sinus disease and asthma at the same time. So unless they've got some of those indications, you might never explore it, basically.
What about old-fashioned things like chromoglycate, Intel, that I haven't heard of for years but used to be very popular? And
it's still around, and I think paediatricians still use it in the younger age group because it's a completely harmless drug. It just tastes like terrible, and
yes.
the other, the new, the nodochromal sodium is even worse. The Tylade is even worse. It's got some usefulness, I think, in cough, but I don't think I hardly ever use it in adults. I think if people need extra treatment in adult asthma, then I tend to add in extra doses of inhaled cortisone by themselves. Now, there's not a lot of evidence to support that either, to be perfectly honest. There's beautiful work showing that the dose-response curve to steroids flattens out, so that once you get above 800 or 1,000 or 1,500 micrograms of BDP equivalent, beclomethasone equivalent, you get a flat curve with no extra response and increasing side effects.
Yeah.
So the dose response curve does that and the side effect curve does that. So having said that, but I think we've all got patients in whom extra doses of inhaled steroids do make a difference, either at times of exacerbation and I sort of think that any amount of inhaled steroid is better than any amount of oral steroid. So particularly in those patients in whom we have trouble getting off oral steroids, and there are a few of those, then I'd rather increase the inhaled steroid and see if you can get them off. The trouble is they've got such a euphoric effect from the oral steroids, and patients confuse their wellness with the euphoria versus their breathing capacity, and it's very hard to tease that out sometimes.
Some of the inhalers that have become popular, like the fluticasone inhalers, seem to have displaced the beclomethasone. Is beclomethasone still available as an inhaler?
Yeah, only in the form of QVAR. It's the only trade name with beclomethasone in it. I personally don't use it. I think it's a dead drug. Beclomethasone is metabolised into an active steroid by the liver. So it's absorbed into the system, gets transformed by the liver into another active steroid, and that's circulating around. And the data is very strong that above 800 micrograms or 1,000 micrograms thereabout, over a period of 10 to 15 years, you do get cataracts, you do get osteoporosis, you get all the usual thinning of the skin, all the usual long-term steroid effects. So I personally don't use beclomethasone at all. I think if you're going to use any of the newer drugs that are broken down into inactive metabolites, that's fine. So the budesonide, the fluticasone, these are all broken down into inactive metabolites. We don't think they have the long-term steroid side effects.
Mm.
Is there a benefit to using, say, aerosol serotype over dry powder serotype?
I personally don't like to use the Acuhala device.
That's the one that looks like a flying saucer?
Correct.
Yep.
I think the delivery is poor into the lung. The delivery into the oropharynx is 80% at least, so much less gets into the lung. I think if people need serotype as a drug, I always use a puffer and a spacer. I never prescribe an Acuhala. I do prescribe the Turbihala devices, not because I have a particular affinity to the company at all, because I don't, but there are some advantages to the ethamoterol versus the salmeterol. So there are some patients I have on Symbicort as their steroid and long-acting combined agent, and there are a very small number of patients in whom their baseline treatment is the twice-daily serotype, puffer through a spacer, and on top of that I use once or twice or 3 times during the day, on top of that, Symbicort.
Well, it's a lot easier to carry around than
It's easier to
a
carry
spacer
around.
device.
And the evidence is that the long-acting beta-agonist, which is in Symbicort, does not produce the same beta-agonist effects that the salmeterol does. And particularly we're talking about headaches, nausea and cramps. And people don't often ask about those. There's beta-agonist side effects. People ask about tremor and palpitations and stuff, but particularly the cramps is very, very common in beta-agonist use. So, I think ethamoterol tends not to do that quite so much, so I sometimes use that.
So with those very chronic patients, when would it be appropriate to send a patient for additional testing in a lab, and when would you just use your general practice spirometry?
I think if they've been a smoker and you want to know that they do or don't have emphysema, then they need gas transfer test to confirm that. If the gas transfer is normal, they don't have emphysema, by and large. That's the case.
Yep.
So otherwise, if it's straightforward asthma and they've never smoked, I think spirometry is perfectly adequate and you don't need anything else terribly much. There might be some argument for saying, well, I really need to look at the lung volumes to see how big the residual volume is, to see whether or not a prolonged course of oral treatment might be appropriate to try and reduce that. But they're pretty rare, those sort of patients.
Yep. Well, spirometry in the rooms is something that does sometimes cause quite a bit of confusion for GPs, both in getting the patient to produce something that's accurate and reproducible, and then in interpreting the results that our machine spits out. So, Bill, perhaps could you take us through just exactly how you do a spirometry and how you instruct the patient in what they're expected to do so that you'll get a good result?
Christian, what I'm going to get you to do, I'm going to measure how much air you can blow out of your lungs and also how quickly you can get it out. It's what I call the 100-metre sprint of breathing tests. So you get out of the blocks as fast as you can, get down the other end as quickly as you can and as much as you can. So I'm going to get you to hold this in a moment. I'll get you then to pop your mouth over the mouthpiece and just breathe normally. After a couple of breaths, I'm going to ask you to take the biggest breath in that you can manage and blast it out as fast as you can go, and basically don't stop till I tell you. So when you go blue, I'll let you finish. So if you just hold that for me. Encouragement is really important when we're doing this test for patients. Whenever you're ready, Christian, I want you to take a nice big breath into the top, and you'll see that on the screen. Big breath in, right up, and blow. Keep it going, keep it going, keep it going. Push, 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 push. All the way out. And off you come. Good. So Christian's lungs are pretty elastic. And you can see from there he's got a good rise to peak, which is really what we're after with spirometry.
Yep.
Nice decline down to residual volume. The green line that's underneath there, which you will often get in most spirometry software, will give you an indication of predicted data. So that's basically where we expect you to get, so we can see from this particular occasion that we've got a lung function that is well and truly above normal. So we're looking at 115, 114, 102%, and a peak flow of 127% predicted. We only use peak flow as a guide to effort. As a diagnostic tool, it's utterly useless. People with interstitial lung disease, for example, will generate enormous peak flows, but in fact only have small volumes. So if you measured their peak flow, you'd send them home and say, well, stop wasting my time, your lungs are fine, when in fact they've got a major lung disease, which you will miss every time with peak flows.
What does the curve look like if the patient isn't making quite the effort that they need to make? So they think they're blasting, but it's obvious that they're not.
Well, if I wasn't giving the patient the right kind of instructions, so just all I want you to do, Christian, is take a big breath in and blow it out. And out you go. Then that's the kind of thing that we're likely to get. So there's nowhere near, when you compare that with the previous one. So with that effort that we've got there, if we took that as a true effort, you'd basically be calling for medical assistance straight away. Patients will think that what they're doing is reasonably quick, but you need to use words like blast and punch and lots of energy, and use your hands and express with your arm of getting the air out, and just work the patient up to it if need be. One of the analogies I use, which seems to work quite well most of the time, is I make the analogy to a 100-metre sprint. And then if they do something like that, then you can say, and I'm always encouraging, even if they do that, I say, well, that's fine, you got most of it out, but I need you to get it out a bit faster. So I like you to take off like a 100-metre sprinter. Imagine the 100-metre final at the Olympics. Gun goes off, out of the blocks as quickly as you can. There you took off like a marathon runner. So I try and make that kind of connection, so they can see and feel the difference. And then 9 times out of 10 they will do one which is perhaps 90% of what I want. And I say, okay, well, we're now down to 200 metres, let's go over the 100 metres. And it might take you 6 or 8 goes to actually get decent results. And I think every time you start spirometry, if you think it's going to take me 8 goes to get this patient, then you don't get that kind of frustration that is then transferred to the patient that they're not doing it correctly. And if you get it in 3, which is the standard, we need to have 3 blows that are within 150 mils of each other, then that's great, you've done it in 3. But it may take longer.
Some of the patients cough terribly when they've done this, and they find that very distressing and then don't particularly want to do it again. How can you allay that and kind of...
Well, it might sound a little flippant, but I do tell them that I've been doing this test for 37 years and everybody who walks in my room walks out. And try and just allay their fears that nobody has suffered any great consequences from doing breathing tests. Coughing is distressing for them, and you can get to a point where you just need to give it away. If the cough occurs early in the blow, then it's going to be a problem because it interferes with the FEV1. If it occurs at the end, then it doesn't make any difference because all you're measuring is volume. So if I can just get you to take a breath in, blow it out, and when you get about 3/4 of the way out, just go like that. And we can perhaps see what kind of signal that you're getting. Okay, breathe in and out and cough. Okay, so you can see from there, you get this kind of jagginess, but it's occurred reasonably far down the curve, although this bit is obviously too slow. And we're just trying to demonstrate the cough, but that's the kind of signal that you get. You'll get a much deeper indentation if Christian puts his tongue in the hole. So let's just start that and try again. Okay, breath in. Perfect. So that's exactly what we get. We get this sudden dive, tongue comes out, flow goes back up to there. It's surprisingly common error. It's almost as if people's tongues are actually drawn to a mouthpiece. So I get them to put a little bit more of the mouthpiece in their mouth, slide their tongue underneath, and if you just tilt the mouthpiece back that way, then it holds the tongue down. The other thing that happens is people get glottic closure. So they will and just stop. So their glottis closes, and 9 times out of 10, if you look at the patient, you will notice that their shoulders are up here. And in fact, if you can then just put an arm on their shoulder, just press it down so that they just relax all of the muscles around here. I think the real secret to spirometry is just getting patients relaxed, getting them on side, that it's not an invasive test, and we're going to get some good results out of it, and just be as encouraging as you possibly can. Never tell a patient that they've done it wrong, ever. Even if they have, you don't say that.
Well, now that we've seen how to do a spirometry and talked about it, mostly we're left with a list of moderately incomprehensible numbers, and I think most GPs will understand a forced vital capacity and what it might indicate, and an FEV1 and what it might indicate, but there's often 3 or 4 other sets of numbers and sometimes a flow volume curve as well. Could you just talk us through it?
Yeah, I can just do that very briefly on a simple diagram, which is like this, so that this is in seconds across here, so that will be the FEV1. If you draw a tangent to that curve, you'll end up with flow. So you then plot a whole pile of flow against lung volume, you end up with a flow volume loop.
Yep.
So a spirometry or volume time curve is the same as a flow volume loop, just mathematically altered. Okay? So now we have a measurement of flow volume. So, and this is the typical shaped curve like this, and the inspiratory loop is down here. This is the expiratory above here, and the inspiratory
most GP ones will just give you an expiratory curve, and often not an inspiratory one as well.
And this is now the peak flow up here.
Yeah.
At that point here, of course, is total lung capacity, and that point here is residual volume. So this is the vital capacity across the axis here. So what these programs do is to divide that vital capacity up into quarters. This is 25% empty, that's 50% empty, that's 75% empty. So F2575 is those numbers. So it's the area under the curve between 25% and 75% of lung volume. That's where that comes from. And this is the part of the curve which is most sensitive to airflow obstruction.
Patients who do very well symptomatically in their normal life, and then they get a cold or they get a chest infection, and they just go right downhill, and they always seem to have that 25 to 75 lighting up like a Christmas tree.
That's right. So that when they're well, that will still be a little bit abnormal quite commonly. It's quite unusual for an asthmatic to have absolutely plumb normal spirometry when they're well. It's certainly possible, and particularly in children, that happens all the time. But as people develop asthma through their 20s and 30s and 40s, they've nearly always got a little bit of airflow obstruction on the flow volume loop, which is their baseline. It was well demonstrated by the guys at Charlie's that becomes irreversible with time, as it happens. But here's some examples. This would be a very typical example of advanced emphysema. This man is only 54 years of age. His body mass index is 16, so you see he's wasted away as they lose all their muscle mass. He's got extraordinarily poor spirometry, 0.45 litres FEV1, and that's hardly any air moving in and out at all, obviously. The vital capacity is 1.72 litres. It's still only a third of normal for this man's age. But the other thing he's got is his huge volumes, and the green bar is the residual volume, is the volume of air which is left behind at the end of a full breath out. It's the gas trapping which they get in emphysema, which flattens their diaphragms.
And you wouldn't normally see this on general practice spirometry, but you will see it in your specialised lab.
Correct. And this man's residual volume is almost 3 times normal, which is extraordinarily high. I don't think I've ever seen that high. The other test that we do is the gas transfer test or diffusion test, which is the emphysema test, if you like, in the context of COPD. It also goes down to interstitial disease or pulmonary emboli, anything that alters the VQ, the ventilation-perfusion relationships within the lung. And this man's gas transfer is only 9%, so he's got terrible emphysema, almost the worst I've ever seen, as it were.
So that must have been quite a difficult test to do, Bill.
It was. And distressing for the patient, in the fact that it's hard work to try and get all that air out, and you just got to be empathetic with that, and also to give them some time to recover in between attempts, rather than just say as soon as he comes off, well, we'll do another one of those, and get this horrible look from the patient as though you were torturing them, which in fact you are.
This was recorded 3 years ago. I actually saw him yesterday, and he's still with us. Interestingly, the spirometry hasn't changed very much.
So this is this terribly skinny, wasted patient
with advanced emphysema.
So is there anything you can do for him?
Yeah. So what I've done is to send him up to see Martin Phillips at Charlie's, because Martin's the only guy doing all this stuff in WA. But there are some things. There was that fad for lung volume reduction surgery where done thoracoscopically, but it's still general anaesthetic and it's a big operation, mortality's high. and they basically prune out the upper lobes of the lungs, therefore reduce the volumes of the lungs, therefore restore curvature of the diaphragm, and therefore they can now ventilate their lower lobes.
The theory being that the emphysema is mostly upper lobe.
Correct. Well, it's not
and
theory.
They've got
you demonstrate that that is the case before you do it, obviously.
better lung function in the bottom.
So what that does is double their FFE1, but it doesn't change their life expectancy. So the surgeons, because of the risk of doing the surgery, the surgeons have shied away from it, and we tend not to do it.
Sounds like the patient gets some quality of life out of it.
They do. So coming out of that is this concept that if you put in one-way valves in the upper lobe bronchi, which let air out of the upper lobes but not back in, they auto lung volume reduce and get the same sort of benefit. And there are some very interesting work being done and published about that. It's not the be-all and end-all just yet, but it's very interesting happening. The other thing that can happen is that you can actually create a hole with a surgeon through the skin, directly through here, into the upper lobe, into these big emphysematous bulli.
Yep.
And that lets air out because it doesn't get back in because there's so much airflow obstruction that tends to come out more than it flows back in. So they tend to auto reduce as well.
So it's making a percutaneous one-way valve.
Correct, yeah. And that just sits there as a fistula, as a chronic fistula. You can actually put a scope in there and see inside the lungs. That's quite amazing. Yeah, so sometimes those sort of things are of some benefit. If a person, for instance, can't get a lung transplant, or which is unlikely to happen once they get to a certain age. So here's a typical example of a woman with interstitial lung disease. She's 79 years of age, a bit on the overweight side at 29.5 BMI. But you can see that her flow volume loop is very up and down. It's a tiny little curve, 56% FEV1 and 51% vital capacity, and the ratio is 82%. So it's a very high ratio, and that's what you see in restrictive lung disease, where the lungs are quite small. There's no airflow obstruction, so the air goes in and out very quickly.
But there isn't much lung for it to go in and out of.
And here
is that why the FEV1's so far down?
Yeah, that's right. And here the mid-expiratory flow is actually high in percentage terms. It's 88%. To go with that, her lung volumes are reduced. The total lung capacity is only a third of normal, and the gas transfer is also low. It's 20%. And correcting up a little bit for the size of her lungs. So she's got reduced spirometry with a restrictive pattern, reduced lung volumes and reduced gas transfer, and that's what you see typically in interstitial lung disease. This woman has pulmonary fibrosis.
With the ratio, the FEV1 FVC ratio, sometimes it's seen to be, it's looked at and thought, well, that's normal.
It looks normal.
And nothing else is investigated.
So the clue there would be the forced vital capacity, which
being reduced
should
and
be
the
quite
FEV1.
significantly reduced.
Yes.
That's right.
And an FEV1 would be
Similarly reduced.
similarly
By
reduced
about the same amount.
by about the same amount.
But the ratio looks normal. But that's the thing to, in a sense, ignore, or at least take into account the other two figures.
And this sort of patient would also presumably have fine crepitations and a history that might alert you to interstitial lung disease.
And they'll be breathless and commonly have a dry cough as well, as you know. Here's somebody who's on the upper limit of size, so we say 160 kilograms with a body mass index approaching 60, which is getting pretty
Very
large.
large person indeed. Yes.
So here we have reduction in FE1 46%, reduction in vital capacity 45%, roughly the same. The ratio is quite high at 79%. The mid-expiratory flow is also down at the same, 46%. So this is a general reduction in spirometry. Tiny little lungs squashed in there somewhere.
And you wouldn't. What would tell you that, apart from the history? What would tell you that this person didn't have any interstitial lung disease?
So going further down here, the lung volumes are also reduced at 47%, the same roughly percentage, which is interesting. And the gas transfer also reduced at 60%. But when we correct it for the size of the lungs, it comes out at 92%. So the lung parenchyma is actually normal. It's just lungs that are squashed in there. So this is when we see the big difference between the raw gas transfer and the corrected gas transfer, and that's what tells us they don't have interstitial disease, and it's all due to some form of chest wall problem. Kyphoscoliosis is a really common cause, morbid obesity a common cause, big effusions would be a common cause of that sort of pattern.
Okay, so if I saw this patient in a general practice, apart from suspecting that they're a very large person and might be squashing down their lung volumes, I would get something that might look like interstitial lung disease, but I could then send them for lung function tests and that would sort out what's actually happening.
Right.
Correct. And they're non-invasive, there's no radiation involved in the test, which is the other advantage of not doing not having to do a high-risk CT. And of course all these people will be breathless.
Yep.
So it doesn't, the symptoms don't help you. Yeah, they'd be breathless just because they're out of condition, because they're morbidly obese. Here's the last one I've got here is a quite unusual one. This is actually a fixed upper airway obstruction. This woman had a tracheostomy when she was a baby because she got overwhelming pneumonia as a baby. And she's now got tracheal stenosis. And so she has a blunted expiratory loop, so quite a flat across there, and a blunted inspiratory loop. So that's a very typical fixed upper airway obstruction. In other words, it's entirely analogous to when you've got tight aortic stenosis and you feel the carotid pulse waveform, it goes like that.
Yep.
It's the same. It's the same. So you've got a tight stricture of the trachea. They just can't get that peak flow out because it's a tight stricture.
What does a typical asthma look like?
Asthma will be the same as emphysema with airflow obstruction, but the gas transfer will be normal.
Sometimes even elevated. It's not unusual to see asthmatics with a gas transfer of 115, 120% predicted.
Yeah. And of course you'll typically get response either during the test, bronchodilator response during the test, or over time. So the fact that they don't get a big bronchodilator response now on this test does not mean they haven't got asthma. So they might, if they get on high-dose inhaled treatment for a while, they might end up in 3 months' time with 30% better spirometry. So that's bronchodilation over time as opposed to here and now with the one test.
Okay, so when we're doing asthma assessments, there's always this push to kind of do the spirometry and give the patient their 8 puffs of Ventolin or their nebulizer and wait 20 minutes and do it again. How often would you actually see a response?
Oh, in asthma?
Yeah.
All the time, really quite commonly. It's not always the 12 to 15% that you require for a diagnosis. But yeah, no, we see it all the time, that sort of response. Even when they've had their treatment in the morning, you sometimes still see it. We tend to use only 3 puffs through a spacer. We don't use nebulised stuff to do that.
Yeah, that's right. And you don't have to wait 20 minutes either.
No. So sort of 3 puffs, half a minute or a minute apart, and then immediately get them to do it again?
Well, I give them 3 puffs, basically 10 seconds apart, and then we continue with the rest of the test, which gives us time for that Ventolin to work. And Ventolin reaches about 80% of its effectiveness within about 5 to 6 minutes, but ideally leave it for 10, and after 10 minutes, yeah.
Should be fine.
But I understand in general practice, then particularly with a practice nurse who makes it her job easier if she puts the patient on a neb and then runs off and does something else and then comes back. But there's really no need for the neb. And of course, the other thing about the bronchodilator, if they're on treatment already, then you want to try and make sure the patient hasn't taken their bronchodilator before they come in for their test or before they come in for their appointment.
So they would maybe, if we're going to do this kind of test in the practice, we would say to them, don't take your Seretide in the morning or don't take your...
It's about a 12-hour
Symbicort.
withholding period for Seretide and Symbicort, and about 6 hours for Ventolin.
Well, thank you very much, both of you, for joining us today.
I'm sure
Do
it's
you
been
have
a
any
pleasure.
final pearls of wisdom for the GPs?
Well, not from a testing point of view, other than to test. I take the scientist point of view that if you're not actually measuring it, you're not getting the best kind of information that you could.
Through the Respiratory Health Network, we've looked at ways of which we can get access to high quality spirometry and reporting right around the state. It's really difficult. We personally cover most of the southern part of the state, so that's a vested interest which I should declare in that regard. But wherever I do clinics, and the GPs locally know where I do clinics, we actually have full lung function available. We thought there'd be an opportunity possibly to offer spirometry through Path West technicians, but we haven't developed that. So the difficulty is when people are only doing one or two tests, say a month, then they de-skill rapidly. The quality of the tests which they produce is low, and therefore uninterpretable. So that's the difficulty in doing it. So if you're not doing a lot of them all the time. So if you are in a regional centre or you've got a large group general practice, get one person to do all your tests, and then they're doing all of them and they're reproducing, and we're very happy to help learn those processes.
Thank you very much.
Pleasure.
Thank you.
And thanks to our guests, Dr. Peter Kendall and Bill Smith. Now, you'll be able to find patient handouts on exercise-induced asthma, care and use of a spacer, bronchiectasis and vocal cord dysfunction, available for download on the Rural Health West website, again, ruralhealthwest.com.au, And while you're there, you can check out any of our programs going way back to 2008, all available to access on the website. Well, that's all we have time for in this edition. We'll be back on the 6th of September with a program focusing on skin cancer. In the meantime, on behalf of the crew at Rural Health West, good night and thank you for joining us.